morning, everyone. We are here today to meet our expert, Dr. Khilnani, who's a very renowned expert in the field of critical care medicine. So, sir, my first question to you is what are the key challenges with ICU, which ICU physicians face in tackling carbapenem resistance in the ICU practice these days?
So, antimicrobial resistance, Dr. Shetty, is a very big issue in ICU practice and medical practice as it is. So, if I take into your history, in 1980s we were using third generation cephalosporin and cefotaxime, ceftriaxone, ceftazidime, they were common antibiotics used in ICU. Somewhere in 1993, carbapenem came as a magic drug. And then because of the overuse and abuse, everybody started using it in general practice, in nursing homes, in hospitals. I have seen ICUs where 8-bedded ICUs in All India Institute of Medical Sciences where I have worked, where 7 out of 8 patients were getting meropenem. So when you use an antibiotic indiscriminately without any scientific evidence or without any microbiology, without any following the practices of antibiotic stewardship, then the resistance develops. If I could take into your history, the Alexander Fleming in his Nobel laureate speech
Correct.
when he invented penicillin, and that time it was thought that now infections will no more be a problem for
the modern
for
world.
mankind. So he said that the thoughtless person who uses this penicillin indiscriminately will be responsible for death of another person who dies subsequently with penicillin resistance. So he said at that time. Why I am telling you that? Bottom line is that whenever an antibiotic is used inappropriately, insufficient dosages without indication or used for longer than necessary, then antibiotic resistance develops. So therefore, if I talk about my hospital where I work at PSRI now, the carbapenem resistance to gram negative bacteria is something like 70%, 60%.
Okay.
So it is important. It's an amazing antibiotic. In fact, when carbapenem came, it was a magic drug because it has an amazing coverage of gram positive, gram negative, and anaerobes, as you know. But today this has become
Major challenge.
a challenge because it is ineffective. It works because majority of time you are starting antibiotics empirically till the time you get a microbiological evidence. So everybody starts with meropenem and that doesn't work. So as per the WHO by 2050, there will be 39 million deaths because of antimicrobial resistance.
Correct.
And in United States, 35,000 people are dying every year. So that's the data.
So, sir, for basically carbapenem resistance infections, what are the drug pathogen combinations or drug to microbe combination like a drug or antibiotic plus a pathogen or any particular E. coli or pseudomonas combination? Which do you prefer in specific infections?
No, like if you talk about ventilator associated pneumonia,
Yeah.
which has been my research area, that is hospital acquired infection for that matter. So since I know microbiology of my hospital, I do not start with carbapenem to start with because if it is a hospital acquired infection, if I know that resistance in my hospital is 70%, then I am doing big disservice to the patient. Then I go to next level of antibiotics.
Okay.
Now the next level need not be a new antibiotic. Like if you talk about cholesterol, it is a old old wine in a new glass. Colistin was there 40 years back, which we were not using, and now we are using. The newer antibiotics which are in pipeline, like ceftazidime avibactam, is a good antibiotic, and it covers carbapenem-resistant, and also it has a beta-lactamases which are very effective as on date, except for Acinetobacter. Majority of bugs would be sensitive to this antibiotic, but warning, my colleagues is, the way I see this antibiotic being used left, right, and center without any rationale at times, this soon is going to be useless.
Okay.
Besides that, so several antibiotics are at our command, like among the beta-lactamase is ceftazidime, the cefoperazone sulbactam is a good antibiotic. Piperacillin tazobactam is a good antibiotic. Cefepime is a good, but they have defined indication. Whether you are
Specific indications.
yeah, whether you are focusing on Pseudomonas, you are focusing on anaerobes, or focusing on staph, or focusing on. So antibiotic, which I cannot name, one antibiotic which is good, but I think I don't know why the antibiotics which are available abroad, namely meropenem vaborectum, uh,
Imipenem.
imipenem cilastin relibectam, cefdorocol, and others, which are available in the United States. Why they are not coming to India, I do not know. And that is the reason that ceftazidime avibactam has been used in every case. Because if you have a wider range of antibiotics available,
There will be lesser
then
chance of resistance to a
yeah,
particular antibiotic.
yes. Another thing which we are now I am talking little philosophical, that microbiology facility in India in general. I am not talking about Delhi or Mumbai or Kolkata or Hyderabad, in district places. Where are good microbiologists and microbiology practices? To use, to do good antibiotic stewardship, you need good microbiologists and good pharmacologists. Two things.
Correct.
Uh, the fellowship which I did at Mount Sinai Medical School 24 years back,
New York.
New York, yeah. There, the rounds will go on for 4 hours, and they were always accompanied by a pharmacologist, clinical
Okay.
pharmacologist. And he will actually carry a booklet. That time,
Of the
iPads were not there.
about the dosage,
Huh,
and
yeah.
yeah,
So, frequently we'll ask him,
and he'll
in
refer to the booklet and
interactions, dosages and interaction with drug. How many people know what interactions are there with voriconazole with so many
correct.
antibiotics? How many people know that when you give steroids, voriconazole dose has to be reduced? You know, so it's a big area, and I have a particular interest in that. So, but having said that, Indian Society of Critical Care Medicine gave me the responsibility of framing evidence-based guidelines for prescribing antibiotics in ICU in 2017, which were published in 2018, and now they are revised in 2024 August. These are evidence-based guidelines for immunocompetent and immunocompromised hosts, with 900 references and 113 pages. This is a published document, freely available on internet, published in Indian Journal of Critical Care Medicine. So I would actually urge everybody to at least you may not read 100 pages, but first 10 pages, which is executive summary,
So for us,
it
the
gives
abstract is also quite heavy, I guess.
no. But if you want to read pneumonia, you read half page of pneumonia. If you want to read UTI, you read the half page of UTI. That couldn't be difficult if you want to. So why I'm not trumpeting the ISCCM document, but you follow whatever guidelines. You follow the science and use it judiciously. And carbapenem resistance, where our discussion started, is a very big challenge in our country.
Okay. So, sir, since you're an expert in this field, I would like to ask you in depth more about antimicrobial stewardship. So, what are the key antimicrobial stewardship practices which you would like to impart upon and explain about to the younger people about how antimicrobial stewardship practices, the best practices, basic practices it might be, and how it could help in tier 1, tier 2, tier 3 cities where the like fancy things are not available, softwares are not available to take care, drug interaction notes are not available. So, like you practiced in Mount Sinai, where a clinical pharmacologist was available on call, but in a tier 2, tier 3 ICU, it won't be available.
Even in tier 3 also, at All India Institute, we didn't have pharmacologists
Yeah.
coming with us.
Yeah.
We didn't have
So,
microbiologists
yeah,
visiting our
yeah.
wards
So,
and
so
ICU.
what would be your key advices?
So, so in developed world, I'm sure you know, the antibiotics will not be issued unless certified by a
Correct.
pharmacologist. And a team certifies that this antibiotics is justified based on the clinical parameters and, if available, the microbiological data. But same thing is not there in India. The antibiotics are available over the counter, azithromycin everybody is taking for whatever sore throat, and they take azithromycin. But in the hospital practice, I think every hospital, number one, whosoever have ICU setup, they should have their own microbiological data for last 1 year, in the sense that this is the antibiotic resistance in our hospital or our ICU. That is number one. Number two, like we have at PSRI hospital, we have every year we come out with charts of antibiotic use which are pasted in the ICUs and ward. And these charts are made by a committee which has a microbiologist also, and they are actually ratified by me, and they put it. So this guidance should be there in each hospital. This would vary from hospital to hospital. Like All India Institute will have their own guidance. So each hospital, small or big, should have their antibiotic policy. And again, coming back to the guideline, there are various guidelines. There are Spanish guidelines, there are European guidelines, there are Indian guidelines, there are IDSA guidelines. Basically, all guidelines are similar. Only thing, they are tailor made to the
Local population.
local population. So, following the guidelines, an antibiotic stewardship has several components. One is beginning of the initiation of antibiotics, second is monitoring of antibiotics, and most important is de-escalation. And working in All India Institute, I realized I used to go to all the ICUs, advising them on ICU infections. So, suppose the meropenem is started in a patient and patient is there for 3 weeks, 4 weeks, 5 weeks. Nobody thinks of stopping it. And one of the reasons for development of antibiotic resistance is prolonged use of a particular antibiotic. So when you use an antibiotic unduly, there is a automatic propagation of resistant bacteria.
Correct.
That's of course is well known. So summarizing it, that antibiotics should be started only when necessary, with a rationale. The culture should be sent, and now of course the biotechnological based biofire and things have come. Those are, of course, it will take years to be generalized because they are too expensive and not available all over. And antibiotics should be monitored and regulated and de-escalated at times. That's the
Okay.
only way to control antimicrobial resistance at this moment in our country.
Okay. So, sir, how good is a biofire in diagnosing these infections? Because it's been used left, right, and center in higher centers these days. And the cost effectiveness is also a question sometimes because it's very costly as a test. A single test might cost 25 to 30,000.
Yeah.
So, how effective it is, and when should it be used? How should it be used? Any advice on that?
So any equipment or machine or a test is useful only when a person knows how to use it. So I'll give you an example. Suppose a patient has community acquired pneumonia which requires ICU admission and is on oxygen or whatever. And you do a biofire, you do a bronchoscopy or sputum or whatever. You do a biofire and you diagnose it as influenza A. So interpretation of biofire is very important. Now, if sometimes it will show 3 viruses and 4 bacteria.
Yeah,
That's the flip side of it. But quite often it will give you one bug
one bug.
that it has Haemophilus influenzae. Now, and last 1 year I have been using it. So suppose it grows, it's a severe pneumonia, and I know it is because of Haemophilus influenzae. Then he's good with amoxicillin clavulanate. I don't have to give him
Okay.
third generation cephalosporin or carbapenem or ceftazidime avibactam. I gave him only amoxicillin clavulanate and I'm done with it. So, having said that, if you start doing biofire for a patient who has got trivial pneumonia, who is not requiring oxygen, as per the guidelines, he can be managed with only azithromycin or at best amoxicillin clavulanate and azithromycin. Or if you have ruled out only 5 days course of levofloxacin, then doing a biofire is useless. You are overdoing and you are misusing a test and making patients spend 25,000. So the question that you ask, when to use it? Only in serious cases it should be used where the infection is strongly suspected. That is true for even hospital acquired pneumonia. And it's
So does it have a place in, does biofire have a place in community acquired?
absolutely, that's what I
Okay.
gave you an example.
Yeah.
Because today
But serious cases.
if I could give you an example, there was a 59 years old diabetic lady who got admitted with right lower lobe pneumonia, and she had oxygen of SpO2 of 88%. She was obese, she was diabetic, so she becomes a high risk case. The CT scan showed right lower lobe consolidation. Next day we did a bronchoscopy and it showed on biofar HMPV virus.
Okay.
Now HMPV virus does not require any antibiotics. So then I didn't escalate, I de-escalated her antibiotics on the second day itself, and 5 days she was home. Otherwise, to treat severe pneumonia with who has got low oxygen and diabetic and obese, I would have treated her for longer time with more antibiotics. One thing. Second is that when you know the bug and when the pneumonia is severe, there is a definite evidence, recent evidence, that the corticosteroid have beneficial effect. You have to rule out H1N1 because H1N1 is a infection where steroids are counterproductive. So, to make judicious use of steroids, I need to rule out and need the bug. So that is the utility of. Uh, the trouble comes the interpretation of it. The
Okay.
interpretation is that as what is the bin count? You know bin count. The biofire
The
gives you 10 raised to
PCR,
power
PCR.
no 10 raised to power 4, 10 raised to power
Okay.
5, 10 6. So anything less than 10 raised to power 7 and more will be corroborated with culture positivity. That's what the data says.
Okay.
Uh,
And
the
anything more? Anything more?
anything more is anything less may not. Anything which is less than 10 raised to power 6, the significance is questionable. That is one. Pseudomonas,
So it could be false positive.
uh, in Pseudomonas infection, biofire is not reliable. And in staph, it is bin level of 4, 10 raised to power 4 plus is only significant. So there are, doing biofire is one thing, interpreting it
Interpretation is another.
is quite intricate. So it, again, coming back to the point, whatever tool you have, it's important how you want, whether you know how to use it. आपके पास बंदूक है, कहाँ चलाना है वो
चलानी आती है कि नहीं?
कहाँ चलाना है ये पता होना चाहिए. तो biofire has a good future. And if I could give you an example of PCR in tuberculosis, I I did a study in 1992 at All India Institute of Medical Sciences, a blind study where I was doing bronchoscopy and sending samples for coded sample for PCR for tuberculosis. And it was atrocious. Where the cancer was, PCR was positive, and the TB was present, the PCR was negative. In 1993, American Thoracic Society said that PCR is not to be used for diagnosis of tuberculosis. Over a decade, today PCR is the standard of care for tuberculosis. So this technique is bound to improve. Today it is costing 25,000. Mark my word, 5 years down the line it will cost 2,000 and 3,000
Okay.
rupees. Because when the technique is generalized, the cost will come down. And there will be improvisation of this biofire, or whatever
Less
you call
false
it,
positives.
and we would also learn how to interpret it.
Correct. Thank you, sir, for your insights on this topic on biofire and on carbapenem resistance. So, any questions from the audience? So,
Sir,
yes.
I'm Dr. Sanjeev from Patna. Actually, recently, I have given this topic to my DMS student as a thesis topic, that how biofire is the better option in comparison to the conventional culture sensitivity test. So one thing usually in seeing that this biofire is usually we get a report with the tracheal culture and hardly get from the blood culture. And another problem was that usually sometimes we get the so many bacteria are positive. So we just excluded those which has been 10 to the power 3 or less. So we excluded in spite of that, sometimes we get the 3 or 2, sometimes more than 3. So it's a very much perplexing us.
No,
So,
I've said
so
in,
we just think that could be contamination or something else. Sir, what is your say, sir?
so
And you just told that it is the if you 10 to the power 6 and less than that, then you should exclude
no,
those.
you cannot exclude. We are learning. We are learning. These data are coming. So one thing should be understood: it will never replace culture.
Yeah.
That you said. I don't agree with you. Culture is going to remain the gold standard. That is one. Now, what is biofire? It is a gene-based test which detects the genes for which the primers are present in that particular test. Like uh, so many bacteria or viruses, like one Staphylococcus, I don't know, mirabilis, that is not included in the biofire, so it will not detect it. The virus which is not included in that particular panel
That is
will not be So it is not to replace culture. That culture remains the gold standard, but it is for the rapid diagnosis of infection.
Definitely, sir. That is the main one.
That is, and of course, sample collection is important, sample transportation is important, microbiology laboratory, how they are preventing contamination is also important. Only the progress will tell how clinically useful they are. But if I could talk about my anecdotal experience for last 1 year, for severe community acquired pneumonia, I have found it very useful. But I don't rely on it 200%. No, I rely on culture quite often. The culture grows the same work as quite often it will happen, and you will see it over a period of time. Initially, 2 years back, I had the same thought process as you have, but I've changed with changing.
So what do you suggest, sir? We should do both of the tests,
Yes, of
culture
course,
along with the biofire.
absolutely. There is no question. You can't do only biofire and do away with it. The cultures will have to be done.
So now I would like to close the session and thank you, Dr. Khilnani, for your wonderful insights. I would like to tell the audience to give a big round of applause.
Thank you.